are at quarter after, so I might just go ahead and get started because I want to respect everyone's time and make sure that the speakers have the full amount of time for their sessions as well as for any discussion. So my name is Beverly Esue. I'm an associate professor of global health based at the University of Toronto in the Institute for Health Policy Management and Evaluation. I am delighted to be moderating this session, which is titled Social Determinants of Health and Family Economics. It is a poster session, which, I think it's great. IHEA has given space and time for the posters to actually have some time to be presented. So we're going to ask each of the speakers to spend between 2 and 4-ish minutes speaking to their poster, and then we'll take some questions right after each of the posters, and then we'll hopefully have a little bit of time at the very end to have some more general questions or discussion. So let's kick off. Our first presenter is Mr. Alex Hoagland from Boston University, and the title of his poster is The Value of Health Information and Learning About Family Risk. Over to you, Alex.
Thanks so much, Beverly. Can everyone see the screen all right? Obviously, I think, like most of us, I don't expect everyone to be reading the poster while I talk, but I wanted to put it up so that I could at least highlight a few key results from the paper. So my name is Alex Hoagland. I'm a PhD candidate at Boston University in the Department of Economics. I'm going to be on the job market in the fall. So this poster represents a very condensed version of my job market paper, the title of which has changed, but I couldn't figure out how to change it on the conference website. So the current title is An Ounce of Prevention or a Pound of Cure, the Value of Health Risk Information. So this poster takes as its starting point a strong, robust discussion in the literature about deviations between what a rational, kind of almost robotic utility maximizing health agent would do when making choices about their health needs, such as buying health insurance or choosing the appropriate level of medical spending, and the behavior that we actually observe consumers making. A lot of policymakers point towards information or lack thereof as a key determinant for why consumers make mistakes when making these choices. But less attention has been given to kind of the rationale behind how consumers interpret new health information. And that's the focus of this paper. So I examine how family members respond to information that they receive about their health risks. I look in a very natural setting. So when household members experience a new chronic diagnosis in the home, I examine the extent to which that generates informational spillovers to other household members in their medical spending choices and their plan choices, and then explore mechanisms behind what might be driving these changes and ultimately what the welfare effects of learning information about one's health risks are. So I focus on a sample of privately insured families in the United States, and show that when these household members are exposed to either their child, their sibling, or their spouse being diagnosed with a chronic illness, they increase their out-of-pocket spending after the diagnosis. So this bottom left figure here in the poster showcases kind of the foundational result, illustrating that household members increase their spending on the order of about 10% annually following this new receipt of health risk information. And this effect is very persistent for multiple years following the diagnosis. I then spend a good chunk of the paper discussing potential mechanisms for why consumers are responding in this way, and really come to the conclusion that household members are reassessing their own beliefs about risk. So I rule out kind of possible alternative scenarios such as induced demand or moral hazard effects arising from kind of the cost-sharing scheme of being on a shared plan with your family in the United States. I also rule out salience effects, such as the effects of going through general health trauma. I show instead that household members seek out care that's very specific to learning information about their risk for a particular disease. So if your child is diagnosed with diabetes, I see family members investing in care surrounding screenings for diabetes specifically. And then finally, I rule out kind of more general features about learning about the healthcare system. So all of these kind of reduced form evidences taken together suggest that household members are learning information about their risk, reassessing their own beliefs about risk, and then making choices that are different because of that. And so I turn in the second half of the paper to a structural approach that estimates the welfare effect of receiving that information and changing choices appropriately. And the structural model implies that there are large changes in household beliefs following this receipt of health information, but that these choices are not necessarily welfare improving. In particular, I find that household members increase investments in low value services, and that many households, if we consider kind of a counterfactual world where they are have some bounds placed on the extent to which they can update their beliefs, they might have better welfare outcomes, suggesting that what might be going on is a high degree of over-responsiveness to this new health risk information that actually generates welfare losses in many cases. And this has important policy implications for kind of optimal information revelation in the large scale for health policy. So I think I'll stop there and take any questions, but thank you very much.
Okay, thank you very much, Alex. Do we have any questions? I might take liberty as chair moderator and ask the first question. Alex, I wonder if you can comment on the ways in which you found some of the social determinants of health and maybe even to some extent structural determinants of health factor into this decision making, and the ways in which that may or may not impact learning about the health system and how that is accounted for within the model.
Yeah, that's an interesting question. So my structural model in particular is designed to kind of disentangle multiple mechanisms contributing or arising from these effects. In particular, there's kind of the pure financial channel. You know, you're spending more on a child who has diabetes, and so that changes the conditional price of care. But also you might be learning about your relationship with your physician, who might be prescribing more tests for you, or you might be learning what it means to get care covered by an insurer. And so I attempt to address this by, in the reduced form section of the paper, looking at specific populations, for example, populations who are already taking preventive medications prior to the health event, so those who already kind of have experience with the healthcare system, and examining them separately. And then in the structural approach, I also kind of model that learning separate from learning about risk, and am able to kind of identify belief formation separately from these other possible channels.
Okay, thank you. All right, well, we might stop there and move on to our next presenter. Thank you very much, Alex. So next up, we have Julie Hudson from the Agency for Healthcare Research and Quality. Over to you, Julie.
Hi, so this is co-authored work with Trisara Berdal, also at the Agency for Healthcare Research and Quality. And this is sort of part of work that we've been doing on family disruptions and the impact on children. So this one looks specifically at moves, all right? So this research is studying the impact of a residential move on whether children lack a usual source of care. Residential moves can occur for a variety of reasons, ranging from family preferences and job changes to family instability and home insecurity. Prior research has found that housing instability is associated with a variety of negative health and developmental outcomes for children. And furthermore, we hypothesize that even for children with stable families and housing, that changes in residence may disrupt longstanding relationships with medical providers. We use the Medical Expenditure Panel Survey's longitudinal files to follow children over a 2-year period, and we can observe residential location 5 times over this 2-year period using census geographic measures like state and block and tract, and as well as longitudinal and latitude coordinates. We're also able to observe whether children have a usual source of care at 2 points during the 2-year period in rounds 2 and 4. We use OLS models on lacking a usual source of care with a variety of controls for child and family characteristics. And the key variables of interest in this presentation are going to be the move indicators. So we have separate models, one that uses indicators using census moves. So, whether someone moved state, county, tract, or block. And we use the longest move that has occurred during the 2-year period. The other model has move indicators that indicate distance of the move. So again, the longest distance moved over the 2-year period. And with these models, we try to identify first how many children experience a move over a 2-year period, whether residential moves are associated with lacking a usual source of care among children, and whether the relationship between moves and lacking a usual source of care vary by the distance of the move. On the first question, we're able to find that over 30% of children experience a census move during a 2-year period. And we were pretty surprised by that number. And furthermore, that children who experienced a move were more likely to have experienced a lack of usual source of care over the 2-year period at 24% versus 14%. Our OLS results using the census measures show that children are more likely to lack a usual source of care if they had experienced a more significant move. So you can see here that children who have moved across states are 30 percentage points more likely to have experienced a lack of source of care compared to someone who hadn't moved at all. But in the shorter moves, like a track move, it's only 3.6 percentage points. And we normalize that by looking using longitude and latitude, and you can look at the similar results found when we use the models that use distance categories. We also are able to identify where the timing of the move. So this slide shows for children who have moved between rounds 1 and 2, we're able to look at whether they lacked a usual source of care at round 2 and whether they lacked a usual source of care at round 4. In this case, we find that that when someone moves, the change in lack of usual source of care persists over time, but it improves. So a child may see a large change in the probability of having a lack of usual source of care at round 2, but for some families, they're able to rebound by round 4, but we still see residual effects by round 4. Furthermore, we're able to look at whether or not a move between between rounds 2 and 4 have different impacts. And we can see that in these models, before the move in round 2, we see no difference in lacking a usual source of care, but after the move in round 4, we do see one. So we feel pretty confident that there is an association between having a move and having a lack of usual source of care, but our study has several limitations. First, because MEPS doesn't allow us to have any reason for the move, we can't estimate sort of the impact of a voluntary versus an involuntary move. We're also unable to really assess the difference between causality and correlation, because the reason for the move could also be affect the ability to obtain care. So for example, if the reason for your move was the inability to pay rent, it could also be likely that your child is, unable to have a usual source of care because of financial burdens. So we need to do further work, and we look forward to hearing from anyone who has any questions or comments.
Thank you very much for that, Julie. I'm just mindful of the time, and so if are there any quick questions for Julie?
I have a quick question.
Sure.
Do you have information about the quality of the original city or neighborhood and the quality of the new neighborhood or the city?
We could add those in. You mean sort of like percentage of providers available? Yeah. We don't currently include that, but that's a great suggestion.
Okay, thank you.
And I see Eileen has her hand up as well.
Hi there. Thank you, Julie, for a really interesting presentation. I just wondered, did you control for any changes in household composition between the moves? So like if the move was the reason for the move or a proxy for the reason for the move, like a marriage,
like a divorce. Yeah. So what's interesting is we have other research that we're going to look at the effect of divorce on these usual source of care. So in this model, we're just controlling for whether or not it's a 2-parent family or single parent family. Right now, that is, we haven't looked at whether that changes over time, but I can look at that. That's another good recommendation.
Thank you.
We're also
Okay.
gonna look at like the effect of death and imprisonment and things like that.
Okay, so I want to be really mindful of everyone's time. So I see I know, Meron, you have your hand up, but I wonder if you mind popping your question in the chat and maybe Julie can respond to it before she has to jump to her next session, if that's okay. Okay, so let's move us along. Next, we have Francis Ilika, who is going to present. If you could pop your poster up. Thank you.
Hello, everyone. I'm happy to make this presentation from work that the Health Policy Plus, funded by USAID, did in Nigeria, supporting a key health policy reform by the government. This reform is called the Basic Healthcare Provision Fund, and it's targeted at ensuring a basic minimum package of care to people, especially the poor and vulnerable, especially at the primary healthcare level. So one of the key provisions of this reform is that it should be focused on maternal and child care. However, this study was done at the time when this intervention was being designed, before the implementation actually commenced. And so it wasn't clear yet what role women, who were meant to be the major beneficiaries of this intervention, played in the design as well as in the implementation. So of course, we conducted an gender and equity analysis to find out gender and equity considerations with regards to how this scheme is being designed and how it's planned to be implemented, and then identify potential challenges, and then recommend areas of improvement, because this was in an ongoing project. Recommend areas that we could mainstream gender into development of the implementation plans in order to implement this strategy, this policy reform effectively. So we collected data through review of key policy documents, key informant interviews. Now, some of the key results that we found when we did this was that with regards to knowledge, beliefs, and perceptions, there was this overall knowledge that gender and equity was important, that there was a need to mainstream it into the work that was going on, into this key policy reform. However, a lot of people did not have any idea about how to go about this. And there was this subtle denial of the existence of gender and equity disparity amongst most of the respondents, where they felt that, oh, of course, we're being equitable in the way that we are running this project. So with regards to practice roles and participation, we actually found that women faced more barriers with regards to lack of information and awareness of the services and risks that they had with regards to accessing basic maternal and child care. They also had financial barriers, lack of transportation, low access to finances to be able to access basic healthcare. And this was also another area that we found to be inequitable. And then when we looked at the leadership, power and decision making, we found out that predominantly across the 4 states and the FCT, 3 states and the FCT that were studied, men made up mostly the leadership roles in the agencies, the key agencies that were driving these reforms. The boards were mostly made up of men, except in one of the states, Abia State, that had a 40% women representation. So another thing we also found was that men oftentimes would see primary healthcare as a woman's domain. So most of the times they don't go to the primary healthcare centers because they see that as women's clinic. And because of that, they are not aware or conversant with the paucity of basic infrastructure, drugs, commodities, and essential things that were lacking in this healthcare facilities. So they were not really in the best position to design the interventions that were aimed at improving the conditions of these primary healthcare facilities. So in conclusion, we recommend that there is a great need to improve awareness about the gender barriers and equity barriers and disparities that occur in the implementation of major health policy reforms, because the Basic Health Care Provision Fund is actually not an exception here. So in addition to raising this awareness, it's important to inform people about how this needs to be managed. So how do we make sure that there is adequate gender and equity representation in design? How do we engage people, and how do we make sure that the people who these designs are being made for are represented in decision-making process? So to be able to do that, there will be a need for an intentional and conscious targeting of the key vulnerable groups, including women, in the design, leadership, and implementation of these key interventions. Thank you for listening.
Thank you very much for that presentation, Francis. Any questions? I might lead off. So Women in Global Health, which is a group that has gained a lot of many chapters now around the world, and is doing quite important work looking at women's leadership and women's role within decision making. Sort of one of their taglines, they have many, is that global health is delivered by women but led by men, and they've done a lot of interesting analyses of gender disparities in leadership around the world. So it aligns really well with some of the findings that you found, I should say, unfortunately, because we are trying to find examples where this doesn't happen. And so you towards the end started to point to the need to have some more targeted mechanisms to ensure female participation, not just in leadership, but also in implementation. And I wonder if you can speak to any ways in which you're seeing, either in your setting or in other settings, that this mainstreaming of either the gendered analysis or participation is actually taking place to support health policy decision making.
Thanks,
it's a long
Beverly.
question, sorry.
Yes, using the result of this, we were able to come up with a gender mainstreaming plan. And one of the key things that we were able to achieve from that plan was make sure that there were women representatives in the boards and in the leadership roles in the agencies that were responsible for driving this reform. Now, what were some of the things that we did? We engaged key policymakers. We invited them to evidence synthesis, policy dialogues, where we engaged them on these findings. We also went the extra step to make sure that this was enshrined in the laws and the operational guidelines as a way to guide against this, because we may not be there tomorrow making the same case, making the same advocacy. But when there's a legal framework that protects it's in operational guidelines, then it's possible for this to continue to perpetuate. And as a result of that, many of the states actually got women groups. So there was a statutory, allocation or a statutory position for women groups to make up a significant membership of the board.
Thank you. Okay, any final questions? All right, we can feel free to use the chat, everybody, if you want to send questions between each other. Okay, so we will move on to our next presenter. We now have Sadiqul Islam, who's from Laurentian University. Over to you.
Okay, what happened to my, just a second. Okay, can you see the screen? Possibly it's not that clear. But anyway, can you hear me and can you see the screen?
I can hear you and I can see your screen.
Okay, so my topic is health inequity in Bangladesh. And I will be very brief given the limited time. Bangladesh has achieved significant progress in many health indicators. In fact, the performance of Bangladesh, I would say, is better in many indicators compared to countries like India and Pakistan. But health inequity remains substantial in Bangladesh, and it is persistent. And so I'm going to report some findings. So basically, how do you measure inequality? So there are all sorts of measures available now. Possibly you are familiar with the indicators of inequality from, let's say, health equity assessment tools from the World Health Organization. And there are a couple of inequality dimensions also. So inequality dimension can be income, education, gender, or place of residence. I'm talking about urban versus rural. And of course, there are other measures of inequality, like all sorts of concentration indices. So the evidence on inequity in Bangladesh is somewhat mixed. So I'll just give you a simple statistic about the disparity in health indicator across wealth groups. So for example, if I take stunting, which is height age ratio, if it is below 2 standard deviation, that's a sign of malnutrition. So for the poorest quintile wealth group, that figure is 40%. For the richest group, it is only 17%. So there's a big gap. And I can mention other indicators. And so what is the situation overall? If you talk about basic indicators like vaccination, treatment for diarrhea, infant mortality, on these indicators, the inequality has declined in Bangladesh. Okay, now there are all sorts of measures, as you say, absolute inequality, relative inequality, and so on. How about the higher level of indicators? So if you take, for example, births assisted by trained medical personnel, antenatal care. So when I talk about higher level of medical services, then inequity is substantial and it has not gone down. And that inequality is pervasive when you talk about wealth inequality or income inequality. Inequality across education has somewhat declined in Bangladesh, so that is a good thing. But still, on many indicators, inequality between the urban and rural areas is pervasive. And so obviously, the government should pay attention to this problem. It is not enough to reduce the level of, let's say, some unfavorable health indicators. It is important to focus on inequity and inequality. That's it. And if there is any question, I would be happy to answer. Thank you.
Thank you very much. Do we have any questions? I might ask a quick question. Maybe
Sure.
it's a quick question, maybe it's not. You mentioned some of the indicators that have been around for some time and are used routinely within research. From your perspective, as applied in Bangladesh, do we have the right indicators of inequality? And are we using the right indicator? The right indicators, are these indicators, and so what do I mean by right? Do these indicators address, magnify the issue, the inequalities that exist within populations, and have they been shown to be influential in making change?
As you know, for example, the World Health Organization, it presents information about over 35 indicators. So for some, the inequity is going down, but for many others, inequity is either persistent or has not gone down. So I mentioned a few, for example, births assisted by trained personnel or birth delivery at medical facility, or antenatal care. And there are other related indicators which are above, I would say, the basic indicators. And there you have significant inequity in Bangladesh. I don't know whether I have answered your question, but I
No,
looked at many indicators. As I say, not all the 35,
Mhm.
but quite a few. So the
Okay.
evidence is mixed.
Thank you for that. Now, I see there's a couple other questions or hands raised. I wonder if you mind putting your questions in the chat and then we can respond to them in that way. I realize I accidentally skipped over Murong, so we're going to just backtrack and go to Murong Yang from the University of Oxford before moving on. Sorry about that.
Hopefully you can see my screen now. Yeah. Okay, thank you. So hello everyone, I'm Murong. I'm a PhD student in population health from University of Oxford. This e-poster shows one of my diffuse study in which aims to investigate the relationship between family income and children's mental health from childhood to adolescence in the UK, and also to explore the potential mechanisms that might explain the relationship. There is evidence show that children from low-income families are more likely to have worse mental health than their wealthier peers. However, how does the association change across different ages, and what are the potential mechanisms underlying these are still very unclear. And understanding the association between the family income and children's mental health is very important to tackle the public health problem. So that in this study, I used the data from the UK Millennium Cohort Study, which is a nationally representative longitudinal study of around 18,000 children born in the UK between 2000 and 2002. The study is constructed based on widely used framework, which is health production function of Grossman 1972. So basically, this framework shows that children are born with initial endowments, and their health can be seen as parental inputs and other factors. And this study is also constructed based on the parental stress and parental investment theory. So the outcome here is children's mental health problems. They are measured by the total difficulty scores derived from the strengths and difficulty questionnaires when children aged 3, 5, 7, 11, and 14 years old. The exposure is permanent income, which is calculated by averaging the equivalized annual family income up to the current survey. You could understand it as a long-term averaged family income. And I also controlled for a set of covariates, including initial endowments, confounding factors, parental stress mechanisms, and parental investment mechanisms. So the study is a cross-sectional analysis from children aged 3 years old to 14 years old. The first result shows a statistical result. As you can see from figure 5, when children were aged 3 years old, there are around 14% of them having mental health problems. And this decreased to around 5% at 5 years old and increased gradually by 10% at 14 years old. As for the permanent income, is kind of relatively stable across the groups. And the key findings is shown in figure 5. As you can see, the marginal effects of lowering permanent income are all smaller than 0 in all model specifications and in all age groups. This means that a 1% increase in permanent income is associated with a decrease in the probability of children having mental health problems. And this association is mediated via the parental stress mechanism, parental investment mechanisms, and especially parental stress mechanisms. So in conclusion, family income is shown to have a protective effect on children's mental health. And part of this can be explained by mechanisms such as parental stress and parental investment mechanisms. And this also indicates that policies that target income redistribution may address child mental health inequalities. And that's all. Thank you. Very looking forward to feedbacks and questions.
Thank you very much for that. Any questions?
A quick question. Is mental health in your, maybe you did the regression analysis, right? Is mental health a binary variable or? Okay.
Yes, yes. So the variable is based on strength and difficulty questionnaire. So we can get a continuous variable. And there is a validated cutoff to indicating whether a children has mental health or not. So I use that cutoff to generate a binary variable.
Thank you.
Okay, thank you very much. All right, so we will move along to our next presenter. Our next presenter is Danny Rivera. If you can come on screen for us.
I can see my screen.
Yes, we can.
Hello everyone, I brought this from college Marcela Sanchez, but she has difficulties with the internet and will not be able to present the poster. Therefore, I will make the presentation. I'm Danny Rivera. I'm statistical analyst and research in Pro Familia Association in Colombia. I'm going to present the research entitled Social Inequalities Related to Antimicrobial Resistance and Neisseria gonorrhea in Colombia by Marcela Sanchez, Danny Rivera, and Juan Carlos Rivera, research from Pro Familia Association Colombia. The hypothesis of this study is that there are determinants of Neisseria gonorrhea that may be contributing to an IHEA in Colombia. Methods. An ecological study was conducted using a multi-panel in 33 departments of Colombia, including Bogota, DC. The results, the greatest inequalities were in the case of presence of barriers to access to health service, not having the received information on prevention of STIs and illiteracy. The Gandhi intermediate determines 80% of Neisseria gonorrhea isolates are concentrated in the heart of the departments where people received the last information on STI prevention. Recommendations: improving drug and MER information and prescribing systems and interoperability with the epidemiological surveillance system. Support future research on measuring inequalities in IHEA to determine whether inequality is widens or narrows over time. That's all, and very much. Sorry, but I do have to go and show me in the chat for any question. Goodbye.
Thank you very much, Danny. Do we have any questions? Okay, well, we will have time at the end, I think, for some additional questions if there are any for Danny. Oh, sorry, Danny has to go, but he has shared his email address. So thank you very much, Danny. Okay, so in the time since we've started, has Sneha Mani joined us, or the person who might be presenting that work? No? Okay, so we will move on to Harminder Giuliani from the University of Regina, please.
Just give me a minute. I'm just trying to share my screen.
No problem.
Yeah. Okay, so I hope everybody can see my screen, the poster, which is already uploaded on the web. Just want to be very brief. And again, my topic has slightly changed. In other words, I am looking at more at gender-based differences in participation and time spent in physical activity in Albania. Just a little background, although there is a wide amount of literature talking about the correlates or the association between physical activity and various socioeconomic factors, to our knowledge, this is the first and only study that focuses on the PA behaviors in Albania using a national level data. And part of that reason is because there was no existence of data that could help us analyze factors affecting PA behavior in a Baltic country, Albania. Secondly, while there is a considerable body of literature that examines the, as I mentioned, the determinants of PA or sport participation in the high income country context, studies on middle income countries are much more limited. And with Albania being a mid-income country, this study adds to this later body of work. This is important for understanding whether the factors that affect the PA differ in medium or low income country compared to high income country, because the policy implications for PA may vary accordingly. We all know that we have increasing evidence of physical and mental health benefits from being physical activity. Only 46% of Albanian adults actually meet the WHO recommended guidelines of minimum level of physical activity, very recent guideline, which was published in 2020. What we did in this paper, we tried to assess any differences in factors that influence the decision to participate in PA and time spent on PA among Albanian adults, how similar or different those factors are across genders, and to what extent Albanians meet the WHO recommended level of PA. We used 2017 and 18 Albanian demographic and health survey data. We also used a double huddle model to simultaneously assess the influence of demographic, socioeconomic, and lifestyle factors on the likelihood of engaging in PA, time spent in PA. And also we used a separate probit model to analyze the factors affecting the probability of meeting the WHO recommended level of PA given participation. I would like to emphasize that my outcome variable here is a self-reported measure, which is based on respondents' participation in some form of aerobic exercises, which is that increase their breathing and heart rate, such as walking, biking, or jogging, etc., or even commuting to work by biking or walking. Our results suggest significant variations in the likelihood of engaging in some PA, the time spent and meeting the recommended level, by household economic status, administrative regions, occupation, and education. In particular, we found that while affluent Albanian males and females were more likely to participate than poor and very poor Albanians, conditional participation, we found that Albanian rich males and females exercise fewer minutes per week than their poor counterparts. We also noticed gender-based differences in behaviors as it relates to education, age, family structure in the form of marital status or presence of young children in the household, administrative regions, employment or occupation, and also lifestyle factors. For instance, in terms of occupation, although unemployed Albanian men and women compared to them, employed adults were more likely to participate in any PA, but we found the magnitude of results varied by occupation and status. More specifically, employed females who participate spend on average fewer minutes per week than unemployed females who participate. And this speaks to the childcare or other non-market household responsibilities faced by women compared to men. We also found that the pattern of these results were very similar to in meeting the recommended level of PA. Given the rising trend of mortality and morbidity from non-communicable diseases, in particular in Albania, because of since 1990, when Albania moved from more communist to more market-oriented approaches, there is an urgency for the Albanian government to mitigate the problem by developing and implementing a comprehensive national policy on PA. And I would like to emphasize that while the 2018 Global Action Plan by WHO on PA provides a very good blueprint actually for various strategies which help move the PA agenda forward for countries at the national level, our results provide additional and we believe valuable insights for understanding the PA behavior of Albanian adults and to identify target groups most in need of intervention. For example, most importantly, to effectively promote and uptake both the uptake and the higher level of PA in Albania, policymakers need to target males and females differently and address the gender-specific needs accordingly. Given the time, that's all I have to say for now. And if there are any questions, please let me know or reach out to me. Thank you.
Thank you very much. I open it up to the floor if there are any questions.
I have a quick question. Usually the demographic and health survey has a data set for children below 18 years, but possibly that data set doesn't have any information about physical activities of children. Am I right?
That's correct. The information on physical activity were only available for age
Adults.
18 to 59 years.
Okay, thank you.
Eileen.
Hi, thank you for a really interesting presentation. I was just wondering, you mentioned that it was self-reported and it's the first data of its kind. Do you believe the results? Have you any way to test the robustness of the responses, or any reason to suggest that people were under or over reporting?
It could be, and that's one of the limitations I specify in my paper. That could be very likely because I could not measure the intensity as per se in terms of how vigorous or moderate intensity level is. But the question was framed in this way that in a usual week, when you go for walking or biking, that increases your breathing rate. So we conjecture that at least this is of a moderate intensity, if not the vigorous intensity. But you have a very valid point. It's definitely, it's not a very, I would be very cautious in interpreting my results.
Thank you.
Hope I answered your question.
Okay, thank you very much. All right, we're going to move to our next presenter. We have Ivana Krkic from University of York. Mercator, sorry.
Okay, I'm sharing my poster. Hopefully you can see it. So thanks for giving me the opportunity to present in this Congress, in this e-poster session. So I'm Ivana Krkic. I'm a PhD student based on the Department of Economics and Related Studies at the University of York. And today I'm going to briefly and quickly summarize the paper titled "The Effect of a Universal Preschool Program on Long-Term Health Outcomes, Evidence from Spain." So as most of you might already know, early life experiences are considered to be key cornerstones of the brain architecture, which is accountable for determining long-term cognitive and non-cognitive skills in physical and mental health, and also have been found to have persistent effects on later life child human capital development. Evidence has shown that early life interventions, such as, for example, early childhood education programs, can influence child outcomes in many domains, ranging from education, employment, earnings to health, both in the short and in the long run. However, most of the research has focused on programs that are targeted at disadvantaged children, and less is known about the effects of universal early education programs, especially on long-term health. So this is when my paper comes here, and the objective then of this paper is to evaluate the causal effect of a universal preschool program on long-term health and healthcare outcomes. And to do so, I'm going to focus on the case study of Spain, which basically had the universal preschool reform that in Spain we just know as the LOCSE, which basically implied a large-scale expansion of full-time, high-quality public preschool for the years old, implemented in the school year of 1991-92, and that had the particular characteristic that crowded out family care. So how I'm going to do this? So basically, using a difference in difference strategy, I'm going to exploit the timing and the geographical variation of the implementation of the reform to find the causal effect of the universal preschool reform on long-term health. So to be more precise, I'm going to compare long-term health outcomes of those cohorts age 3 before the policy to those age 3 after the policies across individuals residing or born in regions with varying initial intensity of 3-year-old public preschool implementation. I use several data sources. Firstly, for the enrollment rates to capture the intensity of the program, I use the statistics of non-university education, which are published by the Ministry of Education in Spain. And then for the long-term health outcomes, I'm going to use firstly a survey, the Spanish National Health Survey for the weights of 2003 and 2006. And then I'm going to rely on administrative data, which captures the whole universe of hospitalizations and deaths from 1999 to 2008. So here in table number 1, and the only table that I actually have in this poster, I can show you the main results that I found. And basically, the results show that a greater initial intensity of implementation of the reform implied a decrease in the probability of being diagnosed with asthma for individuals aged 3 post-policy, but also find a positive effect on hospitalization rates. And in quantitative terms, this table here can be understood as the probability of being diagnosed with asthma decreases by around 20.6%, and hospitalization rates increase by around 1.3% for individuals aged 3 post-policy when we intensify the initial expansion of public preschool by 10 percentage points. Instead, I don't find any effect on other outcomes, such as self-reported health status, chronic allergy, mental disorders, or death. After these general results, I also conduct some heterogeneous analysis by gender, diagnosis, and parental education. And what I find is that the increase in hospitalizations due to the reform is mainly driven by females with pregnancy-related diagnosis. But I also find that children with parents that have medium educational levels are the ones that benefited the most from the reform, in the terms of having a lower probability of consuming medicines or visiting the doctor. So just as a conclusion, and I'm finishing, Beverly, policymakers, when they design their policies, and when they design, in this case, early childhood education policies, they have to keep in mind that, of course, they are going to have an impact on the outcome, on the expected outcomes, such as it could be education or maternal employment. But they have also to keep in mind, and we have also to study the fact that these kind of policies can also have spillover effects to other long life outcomes and very important outcomes, such as health. And that's all. Thank you.
Thank you very much for that. I have a quick question that maybe I'll start with. Can you comment on how you explain the mechanism through which the universal program would have an impact on asthma rates in particular?
Yeah, so for asthma, there are, I thought, and well, they have been documented and explained by others, 2 main mechanisms. The first mechanism, and it's a very well-known hypothesis, is called the hygiene hypothesis, which was developed by Strachan in the 2000s, which basically says that children that are exposed to more agents while they are while in childhood, as might happen if they are in preschool, they are going to be sicker and they are going to have a worse health in the short run. They're going to be more ill and so on. But this at the same time will protect them and will improve their immunity system to future diseases, above all related to infections, parasitic, immunological, and this kind of diseases. And of course also asthma or other chronic allergy, though I don't find any chronic allergy. The other mechanism that I have thought is that maybe the fact of going to preschool, the fact of going to school might make teachers be aware of the conditions or the chronic conditions of these children. They may detect earlier that they have a chronic condition such as asthma that maybe parents haven't detected before, and maybe therefore they can also treat it earlier. These are my 2 thoughts about the mechanism through which the reform could impact asthma.
Can I ask 2 quick questions?
Sure.
One, is this program, early school program, mandatory in Spain?
Okay, shall I answer this
And
first?
okay, the other question.
Yeah.
Are regular medical checkups carried out in these early school program?
Okay, so regarding the first question, no, it's not obligatory because in Spain, preschool is non-mandatory.
Mhm.
So you just, but the thing was that the enrollment rates were around 10%. And after 4 or 5 years, the enrollment rate increased to around 40%. And nowadays, enrollment rates for 3 years old are around 100%.
Okay.
So, but it's not mandatory. And regarding the health checkups, no, the reform was mainly educational reform. It didn't involve any other kind of health checkup or visits to the family. No.
But
None
I
of
think that's a mistake in developing countries too. Early childhood education programs are being introduced, but I think some elements of healthcare can be integrated too. It shouldn't be that costly.
Yeah, and not only in developing countries, but I also know these targeted policies such as the STAR and all these kind of policies in the UK or in the US that I know that they like go together. It's a pack, but in this case, it wasn't. It was just purely educational.
Okay, thank you.
Yeah, but it's a great related point in that I know I'm based in Canada and dental care is one that's integrated with preschool within Ontario. And so to your point around not just looking at traditional educational outcomes, the importance of actually evaluating these programs for the full breadth of outcomes that they influence. Thank you very much for that interesting presentation. We will move along. We next have Eileen Murphy from the University College Cork, please.
Thank you. Okay, so hello everyone, and thank you for coming along to the presentation. So this is work that I've completed with my colleague, Dr. Adele Walsh, who's also based in the Business School at University College Cork. The motivation behind this, I suppose, stemmed from the changes in families that we're seeing and changes in workplace with higher female labour force participation and the move towards more egalitarian working arrangements within households. Some previous literature has shown that perhaps while we're moving towards having dual income households, the desired equality that we see in terms of life satisfaction and division of labour in the home perhaps is lagging. And this is what we set out to investigate. So we used utility theory as a lens, and we were looking to estimate the association between parents' life satisfaction and several work-related factors, including work hours, quality of work. So we measured this using work autonomy, job security, and job status, and then the effective egalitarian work arrangements. And from this, then we tested 3 hypotheses. So the first one, that an increase in hours worked is negatively associated with working parents' life satisfaction. Secondly, that work autonomy, job security, and job status are positively associated with working parents' life satisfaction. And lastly, then, that an egalitarian work arrangement is positively associated with working parents' life satisfaction. And these hypotheses came from the application of utility theory, as I said, and also previous findings in the literature with regards to these relationships. So in order to investigate this, we used data from the European Social Survey that was pooled cross-sectional between 2002 and 2018 across 15 countries. Ireland was one of those countries, and the full list I can share with anyone who's interested. And we took a subsample from this overall survey, and we were interested where we had parents that were living with at least one dependent child, parents who were in paid work over the past 7 days, and that were cohabiting with heterosexual partners also in paid work. And we looked, we'll see in a moment, at all parents, and then we ran our analysis for both mothers and fathers separately as well, which we felt was something that hadn't been done previously in the literature. They tended to focus on all parents or just mothers. So we measured life satisfaction, or there was a measure in the survey for life satisfaction, where respondents were asked, all things considered, how satisfied are you with your life as a whole nowadays? And this is responses on the scale of 0 to 10, where the higher up, the greater the life satisfaction. And in our sample, the average life satisfaction was 7.45. For females, this was slightly higher at 7.46, and for males, 7.43. We had a range of independent variables then that controlled for work arrangements, so full-time and part-time work hours, work autonomy, job security, job status, the number of children, the age of the youngest child, the parents' gender, their age, their education, and feelings about income. So what we found in using this survey is that there's issues with the income variable. And also because we're looking across countries and obviously different standards of living across them. So we used feelings about income as a proxy for this. And then we ran multi-level ordered probit models. In all, we have 3 models. So you can see those here on the table. And the first model is for, we're comparing full-time and part-time. The second model, we have parents who are working full-time only. And the third model is parents who work part-time only. And each of these models was run 3 times, firstly for the full sample, and then for mothers and fathers separately. So as you'll see here with the results, we found that when it came to work hours, full-time work hours were negatively associated with parents' life satisfaction. And we found that this effect was most significant for working mothers, regardless of if they worked full-time or part-time. While part-time working fathers were most satisfied when they were working longer part-time hours. When it came to work quality then, we found that both work autonomy and job security were associated with increased life satisfaction of working parents. And with regards to work arrangements then, we found that fathers' life satisfaction and partners' full-time works were partners' full-time work hours were negatively associated. So these results suggest a rise in the egalitarian work arrangements was felt differently by mothers and fathers. So translating these results back to our hypothesis, then we did find evidence to support that increased working hours was negatively associated with parents' life satisfaction, also support for hypothesis 2, but we didn't find support for hypothesis 3. And with regards to this, we found that mothers tended to be less satisfied working longer hours and are indifferent to partners' work hours, whereas fathers part-time working who worked part-time were more satisfied with their longer working hours, whereas full-time working fathers were most satisfied when their partner works in a part-time job. So while the results were somewhat unsurprising, it does perhaps suggest that we have some way to go for the ultimate benefits of an egalitarian working arrangement to be felt, and those gender differences exist. And limitation of the work is we didn't have panel data in which to conduct it, but we hopefully feel that the looking at all parents and then looking at mothers and fathers is a contribution to the literature. I'm looking forward to any questions that you have.
Thank you very much, Eileen. Maybe we'll take one quick question so that we can get our last presentation in, and then we definitely have time to come back at the end, but I'll take your question now.
I have a quick question, or maybe just a comment. Some studies show, maybe that is consistent with your results, that the stress level of married women with children and working, their stress level is higher than that of men, because of the so-called double shift hypothesis, that working mothers, when they come home, they disproportionately carry out household responsibilities.
Yeah, so we didn't have data on the division of labour in the household, but that's something that we address in the introduction and again in the discussion of the overall paper. Mm-hmm. So yeah, we're very much aware of that. Thank you.
That cognitive labour, I think I've heard it described as. Okay, Harminder, I'm going to invite you to post your question in the chat, or if you can hold out until our final presenter, then we can pose the question to Eileen at that point, if that's okay. All right, so we are perfect. Thank you. I'd now like to introduce Ivana Krkic from the University of Stellenbosch in Cape Town. Over to you, please. And if I have pronounced your name incorrectly, please do correct me, and I apologize.
Yeah. Thank you very much. My name is Ja Mukupete from Stellenbosch University. So I will be presenting our joint work with Dita and Ronel on maize price shock, agriculture production, and children nutritional outcomes in Tanzania. So basically, this study is adding to the emerging literature on the impact of food prices on child growth, which broadly assume that the impact is homogeneous across children, irrespective of the livelihood strategies in which of the household in which a child belongs. Though there are some few studies which try to explore how net seller and the net buyer market position moderate the effect of food price on growth of children, but they overlook the fact that household does not necessarily need to be a food seller, net food seller for the production livelihood strategy, agriculture production to have a protective effect on children from high food prices. So we argue that food production on its own can have an impact, a protective impact on the growth of children from high food prices. So to do this, we specifically now we test how food production can moderate the effect of maize price on the growth of children. So we examine the heterogeneous effect of maize price shock on the growth of children from food producers and non-food producers. And we also explore the potential mechanism through which this effect through which maize price shock affect children. So we use the data from the LSM data by the World Bank for Tanzania. So we construct several variable, like key variable of outcome variable of interest. We constructed H4A z-score, which we use to measure growth of children. We also constructed a variable for micronutrient consumption and household diet diversity. And we also constructed a variable for calories of maize consumption in the household, which we use it as a proxy for low diet diversity in Tanzania, for Tanzanian context. To classify household to food producer and food non-producer, we based on the information on the food consumption in the household in the last 7 days. So if the household consume food from stock, from own production, we classify them as food producers, and who buy from the market as non-food producers. And we employ control function with IVs to control for endogeneity, address endogeneity of food production decision. So our results broadly show that the maize price shock has a heterogeneous impact on the growth of children, where the negative effects is on children from food non-producers, and it is positive on the children from non-food producers. But we also notice that these effects are heterogeneous across, differ by gender of a child and age groups. So we saw that female children from food non-producers are more affected than male children from the same households. But also we saw the effect is more negative on children at age group 24 to 35 months. So in Tanzania, this age group corresponded to the stage at which most children are weaned, like they stop breastfeeding and now start to depend or feed on the same plate with other adults in the household. And on the mechanism, we saw that high prices reduced diet diversity in food non-producers household, and it increased diet diversity in food producers household. And the similar finding we see across micronutrients consumption, like vitamins and other micronutrients, of which it reduced micronutrient consumption across food non-producers and increased micronutrient consumption in food producers. So to conclude, we say that we argue for policy to consider this heterogeneity impact of maize prices on children from different households and livelihood strategies, and policies should not policies such as export ban, which we observe that is the most almost often imposed by the government, should be stopped because it prevents farmers from exploiting the benefit of high prices on from the market. Yeah, thanks. Let me end up there.
Thank you very much. Do we have any questions for Ja?
A quick question. There must be households which do not produce food, but they may be rich. I don't think they will be that much affected by high food prices, isn't it?
Yes, yeah, that could be possible. That's why we also controlled for socioeconomic status of the household in the model, so as to account for that.
So what does the result show?
Yeah, the results that I present consist of all the controls, including socioeconomic status. Yeah.
Does that mean gender is sustained as a, so female children are still most impacted in the non-producing household, food producer households, regardless of socioeconomic status?
Yeah, because we also, from the literature, we noticed that there is kind of gender preferences when it comes to feeding. Like there is a kind of hierarchy. So mostly like in the rural areas, men start to eat first, then male children, and women and female children are last. So this would be maybe reflected in what we see from the results.
Okay.
Thank
you for that. Yes, please.
So I was wondering, do you have more robust explanation about what happens between breastfeeding and when they move to solid foods, especially for houses or households where they produce food? So is there a difference between these houses? Because you said there was a marked difference in that age group. So is that marked difference between the houses that produce food and the houses that don't produce food? And then the houses that produce food, why do you have any reason about why that is happening, even though they produce food?
Yeah, actually, there are some results which I have not reported here. We checked on if these food producers household the benefit from increase in prices. So we realized across waves, the income increased rapidly in the year when there was high price spike in that year compared to other years. So we think household managed to produce food, managed to sell part of it, so they enable them to purchase other food from the market compared to non-producers. So because non-producers don't have any alternative, so once the price goes up, it means that they have to rely on the market to purchase food. But food producers, at least they can consume from their own produce, but also they can buy from the market by taking advantage of high price of maize. But one of the limitations is that we couldn't control for the breastfeeding, because like the surveys does not contain information of breastfeeding all waves, but only the first wave. So what we did, we included variables which predict breastfeeding in the first wave as controls in all other waves, just to minimize the bias that could arise from excluding breastfeeding information in the model.
Thank you. Did this have anything to do with the type of food produced? Say quality of the food they were getting, if they were getting more carbohydrates for households that produce more carbohydrates, and perhaps maybe they were producing foods that this little toddlers couldn't eat yet. Did you have any insights in that regard at all?
Actually, we couldn't be able to distinguish based on the quality of food, because the classification is broadly based on what they consume in the last 7 days. So it's difficult to talk about the quality of the food that they produce. Yeah.
Okay, before we close, Harminder, I wonder if you wanted to pose your question to Eileen.
Sure, thank
Not
you
to put
so
you on the
much.
spot.
Yeah, thank you very much. I just wanted to clarify. I wasn't sure, Ellen, from your presentation, how do you define the job status? Because I wonder if the occupation, the type of occupation would have any impact on the life satisfaction, especially by gender.
Yeah, so excuse me, we did control for things like the type of contract that they had and if they were in a supervisory role. So not specific to the industry they had, but like the status of their role more so. So we only controlled for that. We didn't control for industry, which could be worth putting in actually. Yeah, thank you.
Yeah, I wonder if there are any, variations by, for example, blue and white collar job or professional and being in a manual occupation, for instance.
Yeah, I'll just double check, but I don't think we included that. So they're not on the table on the poster. Okay. But we did have a range of other ones. We also, because of the cutoff for what constitutes part-time work and be it 30 hours, 35 hours, we did test for that as well, and the results were robust. But no, we haven't included, because we've years of education, but not the industry. But that's what we're looking at. Thank you.
Okay, thanks.
All right. It's always a good sign when you run a little bit over in a session. I feel like that really highlights how much people are getting out of the session. So I very much enjoyed this session and I learned quite a lot. I actually really like poster sessions because I think you get a tidbit of a lot of different things. And I want to thank everybody for contributing to what I believe was quite a dynamic discussion. So congratulations on your work, and thank you for choosing IHEA to present it here. And I look forward to our paths crossing again. So all the best with the rest of the conference, everyone.
Take care.
Thank you.
Thank you.
Bye.